Hello everyone, my name is Roslyn. I'm a clinical nurse, and in today's video, I'm going to share information about caring for patients on mechanical ventilation, potential complications, and tips for troubleshooting ventilator alarms. So let's get started. So mechanical ventilation is utilized in intensive care and long-term care settings to assist patients who require additional respiratory support. It's also utilized in operating rooms where long cases of surgery under general anesthesia are performed. So let me start with care or essentials for patients on mechanical ventilation. Number one, and the most important thing, is to maintain a patent airway. This is the very first priority right away after the patient has been put on on mechanical ventilation. So it's good to note the position of the position of the endotracheal tube. Check whether it's secure. It should be well fitted. Number two is to assess oxygen saturation by checking bilateral breath sounds for adequate airway movement and also checking on the respiratory rate. Check vital signs, particularly the blood pressure, after a ventilator setting is changed. Mechanical ventilation tends to increase intrathoracic pressure, which could affect the blood pressure and cardiac output. So that's the reason why it's important to check the blood pressure. Of course, as you check the other vitals. Assess the patient's pain, anxiety, and sedation needs, and medicate as required or as ordered. Each institution have protocols of how they go about sedation of a patient on mechanical ventilation. Number five is to ensure you've done a complete bedside check by ensuring their suction equipments, their ambubags and artificial airway are functional and present at the bedside. Also verify the ventilator settings with the prescribed orders. It's good to sanction the patient, but sanction the patient only when it's necessary, when the patient develops excessive secretions. Hyperoxygenate the patient before and after sanctioning, and do not instill normal saline into the endotracheal tube. Sanction for the shortest time possible and use the lowest pressure required to remove the secretions. Monitor for upper airway trauma as evidenced by new blood in the secretions. It's also good to monitor arterial blood gas, that is the ABGs, after adjustments are made to the ventilator settings and during weaning to ensure adequate oxygenation and acid-base balance. Minimize the risk of ventilator-associated pneumonia. Initials for these VAP or VAP. Implemented best practices such as strict hand washing, aseptic technique with sanctioning, elevating head of the bed at 30 to 45 degrees unless contraindicated, providing sedation vacations, and assessing patients' readiness to extubate, providing peptic ulcer disease prophylaxis, providing deep vein thrombosis prophylaxis, and performing oral care with chlorhexidine per facility policy. So now that we've talked about the care and the essentials of patients under mechanical ventilation, I'm going to talk about complications related to mechanical ventilation. Cardiovascular issues are one of the complications that can develop because of decrease in venous return to the heart due to the positive pressure applied to the lungs. Most of the ventilators use the positive pressure. So intervention for this: assess for adequate volume status by checking the heart rate, by checking the blood pressure, and also by checking the central venous pressure and urine output. Also check, or rather assess patient for increasing autopip, which can increase the risk for cardiac tamponade. Another complication that may arise is barotrauma or pneumothorax. This is injury to the lung tissues due to, again, to the positive pressure applied to the lungs. Elevated mean airway pressures may rupture the alveoli or the lung tissues. So intervention for this, it's good and it's an urgent thing. So it's good to, first of all, to notify the doctor, prepare the patient for possible chest tube insertion if it will be required, and also avoid high pressure settings for patients with chronic obstructive pulmonary disease, that is COPD, or patients with acute respiratory distress syndrome, that is ARDS, or a history of pneumothorax. Another complication that may arise is infection. This can happen as a result of breaks in the ventilator circuits, decreased mobility, and impaired cough reflex. So the use of aseptic technique while handling the patient's environment and invasives like the endotracheal tube itself, the IV cannulas, the feeding tubes, and the urethra catheters is very, very important while preventing infection on patients under mechanical ventilation. It's also good to provide frequent mouth care and ensure there is proper nutritional support. Patients should be on continuous feeds regulated by a feeding pump. It's a big no to bolus feeds, as they can cause aspiration and excess accumulation of secretions. So next I'm going to talk about ventilator alarms, potential causes, and interventions. So ventilator alarms happens when something goes wrong in the ventilator system. So number one, high peak inspiratory pressure or PEEP. This can occur as a result of blockage of endotracheal tube due to secretions, food, kinked tubing, patient biting on the endotracheal tube, coughing, bronchospasms, lower airway obstructions, pulmonary edema, pneumothorax can cause the PEEP alarm. So the intervention for this is to assess the lung sounds, suction airway for secretions, insert bite blocks, or administer sedation as per orders if the patient is very much agitated or biting on the endotracheal tube. Assess breath sounds for increased consolidation, wheezing, and bronchospasms, and treat as required. The second one is low pressure alarm. This can happen due to air leak in ventilator circuit or in the endotracheal tube cuff. So first thing is good to locate the leak in the ventilator system, as this can cause the low pressure alarm. Check the pilot balloon as an indicator of the endotracheal tube cuff failure, and replace tubings as needed. Number three is low minute ventilation. So low air exchange due to shallow breathing or few respirations can cause this. So it's good when this happens to check for disconnection or leak in the system. Also, it's good to assess the patient for decreased respiratory effort. Low oxygen saturations can also be recorded. So when this happens, it's good to check on the pulse oximeter, because sometimes it could be malpositioned. So check on the pulse oximeter and make sure it's well positioned. Check also on the SpO2 cables. Sometimes they could be unplugged, causing the low oxygen saturations. And this sometimes can also happen if the patient is having a connective tissue disorder. An intervention for this is to ensure ventilator oxygen supply is well connected, and also observe pulse oximeter wave on the monitor. And of course, ensure the pulse oximeter is positioned correctly. Verify all cables are plugged in as well, and assess the patient for any signs of respiratory distress. Assess also for perfusion. Apnea can also occur. This occurs when breaths are not being taken in properly by the patient, or triggered, or some triggers on the ventilator. So first is to assess the patient's effort. Again, check the system for disconnections. And this brings us to the end. So remember to subscribe, like, share, and drop a comment. Thanks everyone for watching, and see you in the next video.